Dear chairmen, dear colleagues, thanks a lot for having this opportunity to present our case where we helped to reveal hyperthyroidism thanks to our novel non-invasive AI-based system for heart failure telemonitoring. So let's start with the case. It was 99 years old female who presented for the first time at our outpatient clinic for a regular checkup due to heart failure with preserved ejection fraction. 6 months ago, she was hospitalized for acute heart failure. She had also permanent atrial fibrillation and implanted dual-chamber pacemaker for 16 syndrome and also AV block. At the checkup, she was asymptomatic, although she was frail and hypomobile, so it's hard to tell if there was some exertional dyspnea. She had jugular vein distension. At further examinations, her echocardiography, her ejection fraction was preserved, her left atrium was dilated, which is no surprise in atrial fibrillation. She had tricuspid regurgitation, moderate, with a gradient of 35 millimeters of mercury. And in such case, it's very difficult to assess diastolic dysfunction, and I mean especially the left ventricular filling pressures, if they are increased or not, because there is atrial fibrillation, ventricular pacing. From her laboratory findings, she had increased NT-proBNP, but the problem was that we didn't have her previous documentation, so we had only a report from the last hospitalization, which was half a year ago, and it was a decompensated state, so very difficult to compare this. To assess left ventricular filling pressures, we used our already mentioned novel system that analyzes photoplethysmography, and it told us that her left ventricular filling pressures were increased. So we concluded it that there is probably some deterioration of her chronic heart failure, and therefore we went for some extended examinations, and we discovered very low TSH levels with high free thyroxine. We referred her to an endocrinologist, and she was diagnosed with hyperthyroidism with multinodal goiter, and she was prescribed thiamazole 10 milligrams daily. We also increased the dose of furosemide, and the beta blocker was maintained in order to prevent some further deterioration and possible heart failure decompensation. So what are the learning points? Both hypothyroidism and hyperthyroidism may precipitate heart failure decompensation, and as you can see, the filling pressures are the first marker of the heart failure decompensation, which starts already several weeks, usually 2-3 weeks before the symptom onset and hospitalization. Then there are some changes in the increase in intrathoracic impedance due to pulmonary fluid accumulation, and weight change is not a good marker of congestion because sometimes it isn't even present, and if it is present, it usually presents very, very close to the symptoms. So in order to predict heart failure decompensation, monitoring of left ventricular filling pressure is very important. So far, it is only possible doing remotely with the CardioMEMS, this little invasive system, and having the opportunity to monitor left ventricular filling pressures non-invasively and remotely is a big advantage. There are, of course, other possibilities how to assess cardiac filling pressures, but all of them have some disadvantages. Especially, as was mentioned in this case, the echocardiography is usually good to assess left ventricular filling pressures, but there are many cases such as in these patients, atrial fibrillation, ventricular pacing, etc., where echo can be used to assess left ventricular filling pressures. So to conclude, we have used our non-invasive system for remote left ventricular filling pressures, which uses artificial intelligence to analyze photoplethysmography. It's simple, readily available, time-saving, and it is now undergoing CE certification. It was already clinically validated, and we hope we'll be able to include this system in the clinical practice early. Thanks a lot for your attention.
Okay, I think we have time for one question on this case, which is a nice illustration that we have to think at the heart and at the level of the heart, but also beyond, which is actually the spotlight of this year's conference. And the second point I want to make, congratulations on this tool, your remote monitoring tool for measuring left ventricular filling pressures. And if there is no question, there is one question from the floor. Go ahead.
From a cardiology perspective, would it be better to give nebivolol instead of metoprolol as the beta blocker of choice?
So, because of hyperthyroidism, I would prefer metoprolol. Actually, it's very interesting, but metoprolol is nowadays the only liposoluble, so lipophilic beta blocker that is used, which means that it can pass into the thyroid gland, and so it doesn't act only on the level of heart, but also the level of thyroid gland. So in hyperthyroidism, well, there is either recommended propranolol, which is not available at least in our country and in many other European countries, but the alternative could be metoprolol, but definitely not the other beta blockers such as nebivolol, bisoprolol. So, yeah.
Excellent. Thank you for your case and sharing it with us.